Assalamu alaikum wa rahmatullah. This is Dr. Zaid. Today I will be continuing the video. This is part 2 of the primary defects of antibody production. Last time, just a reminder, I explained about X-linked gamma globulinemia, common variable immune deficiency, and selective IgA deficiency. Today our objectives are to know basic information about Igg subclass deficiencies, hyper Igm syndrome, X-linked lymphoproliferative disease. So starting with the first one, the Igg subclass deficiencies. Some patients have deficiencies in one or more of the 4 subclasses, because there are 4 subclasses of the Igg. Of course, sometimes we need to do the total immunoglobulins, and we will see that the Igg, the total Igg, is normal. But that does not mean that there is no problem with the subclass. So this is the idea of this sentence. The normal total Igg does not represent the Igg subclass. So if you are suspecting Igg subclass deficiency, do the subclass test. But there is a problem that this test for the subclasses is expensive and it is not cost effective. So be careful in doing it. IVIG should not be administered to patients with Igg subclass deficiency unless they are shown to have a deficiency of antibodies to a broad array of antigens. So this is for this disease. Second disease, hyper Igm syndrome. And really they like it. Yeah, I noticed that they like it in the questions. It is normal or elevated serum IgM levels associated with low or absent IgG, IgA, and IgE serum levels. Causative mutations, they are 5, which are identified so far. They are 5. 2 of them are on X chromosome and 3 genes on autosomal chromosomes. In the exams, I noticed that they like the X-linked ones, especially the first type, which is X-linked hyper IgM caused by mutations in the CD40 legend. Okay, so let's continue. All such patients should undergo molecular analysis to ascertain the affected gene. Why? Why we should know the cause or how it is inherited? For genetic counseling, for career detection, for decision regarding definitive therapy. Okay, I have one information about only one kind, which is the X-linked hyper IgM caused by mutations in the CD40 legend. The brief for it is HIGM1. Patients have normal numbers of circulating lymphocytes. This is first information. There is no absent lymphocytes, but the P lymphocytes are normal. And these patients, they are susceptible to pneumocystis jirovecii pneumonia. Okay, and they have neutropenia. Okay, so because of the poor prognosis of these patients, the treatment of choice is HLA identical stem cell transplant. This is in the first place. It comes at the first place. HLA identical stem cell transplant. Alternative treatment is monthly infusion IVIG. So the IVIG is not the first choice. The first choice for treatment for these patients is HLA identical stem cell transplant. This is for that disease. For this, now the X-linked lymphoproliferative disease. The other name is Duncan disease. Okay, it is characterized by inadequate immune response to infection with EBV. So when the EBV comes to this patient, he will deteriorate fast, and really he will deteriorate too much يعني. Affected males are usually healthy until they are acquire EBV infection. There are 3 clinical phenotypes. 50% of patients, they will have fulminant, often fatal, infectious mononucleosis. Quarter of them, they will have lymphomas, and quarter of them, they will have acquired hypogammaglobulinemia. Diagnosis prior to onset of complications is difficult because the patients are normal prior to showing symptoms. But early detection is possible, especially if there is a known case in the family, by doing mutation analysis. The mean age of presentation is less than 5 years. Now I finished this video. I want to move to the questions related to this video. So the first question, children with X-linked hyper-IgM syndrome are markedly susceptible to, I mentioned it during the slide, it is E, pneumocystis jirovecii. The explanation is as follows. In addition to opportunistic infections such as pneumocystis jirovecii pneumonia, there is an increased incidence of extensive Verruca vulgaris lesions, Cryptosporidium enteritis, subsequent liver disease, and an increased risk of malignancy. Next, which of the following is the treatment of choice of X-linked hyper-IgM syndrome? Of course, the answer is E, HLA identical stem cell transplant. Which of the following viruses is often fatal if acquired in children with X-linked lymphoproliferative disorder? Of course, the EBV. The explanation is X-linked lymphoproliferative diseases have susceptibility to EBV and the development of hemophagocytic lymphohistiocytosis, which is the abbreviation of it is HLH. There are 3 major clinical phenotypes, the fulminant fatal infectious mononucleosis, lymphomas, and acquired hypogammaglobulinemia. So these are my references. Thank you for listening to this video. I hope you will benefit from it. Thank you very much.